Power Breakfast show, and that was Simply Thomas entertaining us, and of course he'll be taking us to the top of the hour. Now, as you know, every Tuesday we focus on matters health, fitness, nutrition, and this morning we want to do focus on the woman and the changes she goes through when it comes to matters pregnancy. And in studio I'm joined by Dr. Maureen Obiti. She's a gynecologist. A very good morning to you.
Good morning to you.
And thanks for coming.
So
All right, so we want to talk about this process that is considered so natural for many, but for others is a struggle. So let's start with conception, something that every woman, I'm assuming, hopes and dreams that they'll be able to do, but then there are those who tend to have a difficult time trying to get pregnant. What exactly could be the problem?
That's a fantastic question, Kirigo. Now, firstly, I'd like to explain to a lot of women, they think they have problems when they actually don't have problems.
Okay.
Everyone imagines that with a single act of making love,
yes,
that you get pregnant immediately. And it's again understanding that in a monthly cycle we have our periods. It's only about a 25%, less than 25% chance of conceiving in any given cycle. And the reason behind this is because you only ovulate on one day, and that egg only lives for 24 hours. That's exactly one day. So in a whole month you only have a 24-hour window when you can get pregnant.
Okay.
So a lot of people come, oh, I've been married 3 months, I'm not pregnant, what's wrong with me? And for most women, or couples, it's just to reassure them there's nothing wrong with them. If between 9 months and a year, they're having regular sex, and that means about 3 times per week, not using any contraception, within 9 months, more than 70% of them would have conceived.
But we've seen, we've heard of people who 3-4 years later are still trying and it's not working out. So what exactly in that scenario is a problem?
Okay. I just wanted to finish to reassure women so that they don't think they have a problem.
So you're telling me
within a year, if after a year nothing has happened, then definitely something is wrong.
Okay.
And that's where we now come in.
Okay.
Yeah. So I think that was the first point, to just make people relax, that you're married, you've been together, it's a year, it's still okay. But more than a year, then we have a problem. Now, people always think that fertility is a women's thing, and yet actually it's a couple thing. You must remember, I need an egg, I need a sperm, and it's the combination of the two that will give us a baby. Okay. Yeah. And so we always start fertility consultations with the best way would be that both couples come together and you establish whether they have a good relationship and the atmosphere is supportive. It's not always the case, but that's a couple that's good to help and interesting to help, because it's easier to help them if the two of them are together.
So you're saying that factors such as maybe, let's say, my work situation or the family situation, what I'm eating could prevent or lower my chances when it's when I'm trying to conceive? Definitely.
For lifestyle, first we have to establish, are you smoking, are you taking alcohol, are you exercising? So definitely a reduction in those things would improve your fertility, and if you increase exercise, obviously it would improve your general health, well-being, and if you're healthier, definitely your chances of conception would be better. But where I was going was that people always think it's the woman, yet we always need our male partner involved. And if there was any test I was to do first before I start investigating the woman, it would be the man. We have what is called a seminalisis, whereby we first look at what is the general picture and is there something we can deal with, because we'll put the tests we do on women, some of them are downright, it's like almost barbaric. I wouldn't want to go through some of the tests they have to go through. And it's not fair putting a woman through so much and you don't know how her counterpart is. And sometimes the issue actually is male. You must remember that it's just in simples of 30%. So you'll find that 30% is a woman, slightly less than 30% the man, and another 30% will be the two of them have an issue. And then we have a 10% whereby we can't explain why they're not able to conceive, what we call unexplained infertility.
Okay.
Yeah. So if it's the man, their test is really just one, and once you've done that, you know how to move forward for the two, and then we move over to the woman.
Okay.
The woman, in her history, we usually find out, is she menstruating regularly? Does she have has she had any history of any infections, surgery and stuff like that? And then we go into our terrible test. So it's to check, are her tubes patent? And that's, in this area of the woods, one of the most common reasons why women are not able to get pregnant. They could have had a pelvic infection in the past, and TB is also very prevalent in this area. So you find that that affects their uterus, and more importantly, the tubes. And if the tubes are not patent, it means the sperm and egg can't meet, so obviously she's not going to conceive. If she's menstruating regularly, the assumption is that she's ovulating, which is not always the case.
Yes.
Which is not always the case. But then, if her tubes are patent and she doesn't have a regular menstrual cycle, again we look into her hormones to find out, does she have any hormonal factor that can predispose her to not getting pregnant.
All right, and remember, you can be part and parcel of this conversation. 22422 is the SMS line, or you can get us on Twitter. The hashtag is Power Breakfast. Now, something that we also hear, out here, and maybe you can demystify it for us, is the use of contraceptives. They are said, or some people believe, that when you use contraceptives, it hinders your chances of getting pregnant later on in life. Is this true? Is this false? Again, a fantastic, awesome question, and I am very happy to answer that. Now, that is myth. That's all I can say about it. You must remember, even when we are counseling for people, when we're doing a contraceptive consultation, a family planning consultation, one of the things we'll tell people is that there's no method that is 100% guaranteed. And I can tell you, Kirigo, I have delivered people who, from whichever form of contraception, you mention it, they were using it. Okay, maybe the issue was whether using it properly, but they were using it. You find something like a BTL. I think it's obvious that a BTL, that's a bilateral tubal ligation, should have been done properly. But yes, I've delivered a mother who has had a bilateral tubal ligation and is pregnant, and that's a permanent method. Now, what of the reversible methods? Most methods, once you stop using it, if you don't have a problem yourself, your fertility returns immediately. Okay. So the only caveat would be things like, for example, the injection, whereby you'd have to wait the 3 months. Yes. But the 3 months you don't go for your repeat injection, your fertility has come back. So it would be to really find out what other issues are hampering. The contraception has no relationship with her conceiving, her inability to conceive. So some people would ask, but I've had children before, why can't I now conceive? But maybe you had surgery. Even the simple cesarean section is not without complications, and that's one of them. Rare, very rare, but it is possible that somebody could get pelvic adhesions in the abdomen that would block the tubes, which, as I said earlier, would make the woman not be able to conceive. So it's a risk factor, and it's just really just go through her history and try to find out what factor would make her not be able to conceive. So contraception, please, everybody, it's not what's causing you not to conceive. The next one would be the age factor. The older Kirigo gets, she doesn't have a baby, the lower her chances of, getting a baby as the years go by. If she was 26, between 24 and 26, in fact, that was the best time for her to give birth. Myth or...
Now, that, unfortunately, sorry, women, it's a fact. Okay. Yes, we have people who are in their 50s, 40s, still getting children.
In fact, I was going to tell you, pop star Janet Jackson just said she's pregnant. And she's how old? 49?
49.
Turning 50? Yes.
I even have people known to me who are older who've had natural conceptions. But you must understand, they are the exception rather than the rule.
Yes.
Yes, to every rule there's always
an exception.
An exception.
Yes.
And we thank God for them that they've been blessed in that manner. And yeah, I'm sorry, I'm a bit what's the word? I'm questioning.
Yes.
Was it a natural conception? You
Okay.
must also remember that you're right. Between 24 up to the 30s peak all the way up to 35, fertility peaks, and it relatively stays that way till about 35. Unfortunately, after 35, statistics, it's not 100% for everybody, but this is just what we call the rule. Okay. So in the rule, after 35, you find our reproductive fertility drastically reduces. It goes down, and it's even worse after 40. After 45, we don't know actually what we're talking about. So yes, there are exceptions to the rule, but that's just the way the picture goes. So it's really trying to encourage women, if possible. It's just that I can't force you to get a husband by force by 35.
Yes.
We understand that. But if possible, within reason, to try to finish your reproductive life earlier when we can help you. Even response to treatment is pegged on age. The only time when age does not matter would be if you are not using your own eggs, as in you're comfortable not having your own genetic children, you're comfortable with having a donor egg. At that point, the age will not matter.
Donor egg meaning I get someone who's much younger,
yes,
and have their egg implanted in me.
Yes, probably mixed with your husband's sperm.
Yes.
Or if he also has a problem, somebody else. That'll be 100%.
Yes.
Not your genetic. Somebody
else's child.
But it'll be a child you'll carry if you are comfortable, because again, it matters really on your affiliations and beliefs. Some people would not be comfortable with that because of their religion and their beliefs.
Yes.
If that's something you're comfortable, that's something you could be offered. And for me, not wanting to cast doubts on Janet Jackson's fertility, but that would be the question going through my mind. Was it a natural conception?
Okay.
Yes.
You've said something about me being at my peak at 35. And before 35, sorry, between 26 and 35, and that's when really I should be planning to get my children. But then we've heard of people who had your firstborn at 32, secondborn at 35. Does that mean if I want my thirdborn at 37 or 38, then it becomes harder? Is it going to be harder, or is it easier? What's the game like? Because I'm imagining I have already given birth twice, so at 37 it really shouldn't be a challenge. Or does it come to play? Does this a fact that my eggs diminish after 35 come to play? Okay.
As you said, I'm not saying that after 35 you can't have children. I'm not saying after 40 you can't have children. It's just for somebody who has never conceived before, definitely that does come into play. Okay. And even for fertility treatment, we always prefer somebody who has had a history of conception previously. They are much easier to work with, and it's just, if you are going through somebody's history and trying to look at prognostics, having had conceived before is a plus. You understand? But it's not necessarily, it is possible that you've had a 32, 35, then 37 can have a problem, but because you've delivered before, it increases,
it ups your chances.
It ups your chances.
Yes.
But the fact is, your eggs are older, your pool, because like women, we are born with, when we are born, we have all the eggs we have, unlike men.
Yes.
Men produce their sperm as they go along.
Yes.
Okay?
Yes.
So whatever we have, it's what we have. And the older you get, it's getting older, and it's like the body destroys them automatically. So the number you have is also decreasing. And because of that lower number and older age of the eggs, just your fertility is just lower.
Okay.
Even for family planning, you have people like Catholics, they don't like to use conventional contraception. They would like to use the natural type of contraception. I'm very comfortable in somebody over 40 doing that, because I know her own fertility naturally is lower than somebody less than 40,
yeah.
and it's just that and that's the simple way. I would not encourage anybody in her 20s to do natural family planning, because I know that's a disaster
waiting to happen if they're not especially ready for it.
Yeah.
Okay, so let's now move, conception, you have conceived, and then what I have seen, read about is, quite a number of people then tend to miscarry in, their third or fourth month. And maybe we can try and understand what exactly has happened when someone has miscarried. And then secondly, the reason as to why we're seeing quite a number of ladies going through this, because I'm sure you have encountered quite a number of you. I know quite a number of you. I've heard of, so what exactly happens?
Okay. Thank you, Kirigo. Now, for us, when you say a miscarriage, I'd also like to apologize to some women in that we have some terms that sometimes people are not comfortable with. But a miscarriage, medically, what we call a miscarriage is actually an abortion, which I think people have very negative connotations to. So sometimes, forgive us, I'd really just like to beg audiences to just try to understand us.
Yes.
That's the medical term.
Yes.
Okay? Now, and that is any time before 20 weeks of pregnancy. That is what we'd call an abortion. Anytime after that, it will be a preterm delivery. Again, I'm using international terms. Here, I'd say an abortion anything under 28 weeks. Reason being because of our survival rates of children below 28 weeks of pregnancy. Now, if we start, what a lot of us don't know is that a lot of pregnancies go unrecognized. A lot of pregnancies go unrecognized. So we have people, they got their period as usual, maybe it was just slightly heavier or slightly delayed and stuff like that. You just think, oh, I traveled or something like that. But it actually could have been a miscarriage. So if I was to test all women who, before the expected date of pregnancy, actually you find that actually 50% of pregnancies end up in a miscarriage. Okay, but the general miscarriage rate for what is recognized, because that's when a woman missed her period, and then recognized that she could be pregnant, did a pregnancy test or had a scan done, confirmed there was a pregnancy. So in terms of a clinically recognized pregnancy, the rate is lower. It's anything between 15 to 25 to 25%. So why? And now if you look at it, the most common cause now of those that we recognize, if we were to test all the products of conception that came out following the miscarriage, more than 50% or less would be due to some chromosomal or genetic problem with the fetus that came about. Yes. After that, you now have the various other things. So you find there are structural anomalies, okay? So you can find things like fibroids, which are very common, and polyps in the uterine cavity. Then we have infections. We have what we call the touch screen, so things like toxoplasma, cytomegalovirus, herpes. But again, currently we're not testing a lot because it's limited what you can do about it. Then we have, we've talked about infections, we've talked about genetic causes, we've talked about, what do you call it, iatrogenic medication, and again, we talked about, you mentioned smoking, tobacco, alcohol, drugs, and these are all things that are becoming, again, very prevalent in the society. Then we have immune disorders or autoimmune disorders, so people with things like the lupus. I think that's something that's becoming more prevalent in the society. So it's really to go through the woman's history, and really the tests are very expensive and very exorbitant, so it's really from history to try and come about with tests that are logical, because if you did everything, you can spend up to
Crazy amounts.
Yeah, crazy amounts of money.
Okay.
Yeah.
And then speaking on miscarriage, you have an SMS here from Anonymous, and I want from a gynecologist's point of view. Morning, I had a miscarriage a month ago. How long should I wait before trying to get pregnant again? I'd want to hear, you know, your thoughts on this, because I've heard other people, and especially mothers who've gone through, you know, miscarriages. They have different time frames. But from a doctor's point of view, first, do I have a time frame, and ideally, when then should I try next?
Okay, one is to understand that if you had a miscarriage a month ago and you engage in any sexual activity, in that same month, within 7 to 10 days, you're actually fertile again. You could conceive immediately, and physically there's actually nothing wrong with that. The problem is stress, and I didn't mention that. Stress can also cause somebody to get a miscarriage, and the issue is, especially if it was something like we've talked about infertile couples. You can just imagine they're infertile, they're pregnant the first time, and they lose the baby. You can imagine the amount of psychological trauma that woman is going through. So it's we just give it, it's just an arbitrary figure of 3 months.
3 months.
Yeah? So there's no magic behind the 3 months.
Okay.
And the reason we say 3 months is just to give that woman a bit of time to come to terms with what has happened and just settle a little bit. The only thing that will really make her really get over that trauma would be probably carrying a baby in her arms. And probably at that time she may not necessarily forget 100% what happened, but at least it would really ease that trauma. So we don't want to keep them too long, you understand? But we just want to give her time to have at least accepted what has happened and settled and be ready to embark on it. And 3 months is what we just call a minimum. But otherwise it's the woman who chooses when she's ready. So she wants to stay a year and she feels she needs that time to get over, then so be it. We don't have. But for us, we had advised at least 3 months. Then just move on. Take the time out, and then once you feel you're ready to do it, you can embark on a pregnancy.
What about the people who end up having miscarriage after miscarriage after miscarriage? What exactly is going on there?
Okay, now that's what we called recurrent pregnancy losses. Okay, previously we always used to say that it's anyone who has had 3 consecutive, meaning they have to be one after the other, pregnancy losses. And that's when we'd start investigating. But what literature has shown us, and studies have shown us, is the difference between somebody who's had 2 consecutive pregnancy losses and 3 is very minimal. It's about 24-29% for 2, the chances of having a repeat, and about 30 to 33% for somebody who's having a 3rd. So we now are starting to investigate earlier on somebody who's had 2 consecutive pregnancy losses. And as I mentioned previously, the most common cause is a chromosomal or genetic problem with the fetus. So the ideal thing to do, if possible, would be to get those products and have karyotyping done. That's checking what the genetic makeup of that fetus is, to try and find out what the problem was with that fetus. If that's not possible, then it would mean that maybe that both parents would have to go through some array to check out if they have any problem that would make them have the recurrent pregnancy. Other than that would be again check. Does she have this like lupus? Does she have infection? Does she have the thrombosis? Stuff like that. Anything that would cause her to have a miscarriage.
Another one. Hello, I'm Benjamin, and I wanted to ask, my wife complains of abdominal pains and she's 3 months pregnant. What might be the problem?
Abdominal pains 3 months pregnant, I would really, if she hasn't started a clinic, at least have see her doctor. 3 months I think is a bit big for a common cause that's an ectopic. But again, still possible, and if it's very severe. But again, another common cause is that early in pregnancy, before the placenta, because you must realize when you conceive, it's a single cell, there's no placenta formed, and as the baby grows and matures is when the placenta is formed. So initially the first 7 to 9 weeks we have a cyst in one of the ovaries, what we call a corpus luteum. And this corpus luteum is what produces hormones, mostly progesterone and the beta HCG, that maintains the pregnancy. Now, for a few people, that can persist. Again, another common cause could be a urine infection. So does she have any urine symptoms like going to the toilet a lot, any pain when she's urinating? And there are other off-the-cuff things. Could she be having an acute appendicitis concurrently with pregnancy? But it would mean a consultation. Again, find out what are the chief complaints, which exactly area is affected, and then from that we'll be able to figure out what exactly the cause is.
Okay. And there's this, we've talked about this, but I want you to, dispel this notion. There's Kevin from Kisii. They're trying to get a baby with my fiance, but she cannot conceive. What is the problem? Could it be the e-pills she used at first? She has used them thrice. E-pills, I think we didn't touch really on the e-pill, but e-pill is exactly that. It's an emergency pill. So it's like you were using condoms, it burst, or in the unfortunate, I think we as healthcare workers is in a very unfortunate situation like a rape incident, because you would not really want somebody to conceive from such whatever, but really should be an emergency, and the level of hormone in it is much higher than what we have in the conventional pills. So we really don't advise women to use e-pills concurrently on a regular basis. However, as we've said, a fertility consultation involves all that. He is also part of that. So you see, everyone is like, she can't get pregnant, but they forget it's the couple. It's just, unfortunately, it's the woman who carries the baby, so she's the manifestation that the couple have conceived. And there's someone who's asked a question on Twitter and has asked what could be the cause of imminent fertility in men? Infertility in men. Okay, fine. For men, a lot of causes. So you find that, again, we mentioned for men, lifestyle, very important, and that is important. People who have, say, low sperm counts, what we call oligospermia. So for low sperm counts, we start look at, do you take drugs, do you take alcohol, do you take tobacco, do you exercise? Try to rectify a lot of that. In terms of treatment, yes, there are some of us who do give some concoctions, but they've been shown they really don't help. And even at any given time, we can't really again label a man on a single semen sample, because the trend is that the semen count fluctuates at any given point in time. So it's, you have to do consecutive samples to see if there's really a problem. What is a problem is what is called azospermia. Azospermia means there's no sperm in the ejaculate. So the most common reasons could be there's a block in the tubes, what we call the vas deferens, and that is what is called obstructive azospermia. So in that case, those for any azospermia, treatment is always what we call an ICSI. ICSI would be, in terms of what you heard of the test tube babies, in the conventional IVF would collect, those are the people who just have a low sperm count. You try to mix them together with the egg and they spontaneously mix, whereas in an ICSI you take a single sperm and directly inject it into the egg, and then you get the embryo. Then, so if it's not obstructive, we have non-obstructive, and for non-obstructive azospermia, that means the tubes are not blocked, but we're not getting any semen again in the ejaculate. And in that case, most common would be some genetic problem. You have and there are very many causes. So definitely chromosomal analysis of the man would have to be done. But again, even from history and even physical appearance, we can deduce some of the abnormalities. All right, and like you said, it's a couple thing. It's not one person who is responsible for the other. All right, quite a number of SMSs coming in, with different questions. We've talked about Kisii and the e-pill. Sorry, Kevin from Kisii. Someone says, I had a ruptured ectopic pregnancy last year in October and had one of my tubes destroyed, and thus it was surgically blocked. And I have one tube and it is becoming very hard to conceive. What could be the problem? And this is from Mercy.
Mercy. Okay. I'd just like to tell Mercy, we have to remember that if there was a problem with one tube, there's a process that destroyed that tube, and really there's a chance that whatever was doing that to that tube, the same could have happened to the other tube. So again, such a person, I'd try to get them to conceive as soon as possible.
Okay.
Again, check their tubes. Remember I said there was this horrible test whereby how we check the tubes for women. I mean, it's awful. Just check, is the other tube patent? Maybe if we could help her, try to give her some what we call ovulation induction to try and improve her chances of conception. If that's not working, then at that point maybe she could also be a candidate for IVF.
Okay.
But it's to look at it. There's also the possibility that she could conceive and get an ectopic in the other tube. However, it's not all glum. She can conceive and have a very normal pregnancy in the uterus. But for such a person, always to advise them, try to conceive as soon as possible.
Okay.
And if she does, immediately go to have a scan done to really confirm what is the location of. So
for now, because she says, you know, it's hard for her to conceive, that she needs to go back to hospital and have a scan to check whether the other tube.
Okay, it's not a scan; it's actually an X-ray. It's actually an X-ray. Though we can do it by ultrasound. We have a modality whereby we do what we call saline ultrasonography. But the most common is what we call the hysterosalpingography, a HSG, whereby we check the uterine cavity and the tubes and the patency of the tubes. So that would actually be my first step for her in view of her history. Okay. Yes.
I'm thinking a lot of people caught our conversation going on halfway because there's Bilha from Nyeri, and I just wanted to clarify this for her. I'm 38 years old with 2 kids, first one at 22, second one at 27. I'm now 38 years, looking for a third born, but I can't conceive. And we've already talked about this, and maybe you can just quickly go back to it and just answer her because I'm assuming she caught us halfway through.
Okay.
Yeah.
Again, it would be, I'd ask her, is it the same partner she had? So remember, I always say conception, 2 people. 2 people. It's 2 people.
Yes.
If it's the same partner, it would be still, even if it is the same partner, we'd always start history. Has she had any surgery? Has she had any infection? Blah, blah, blah. And then from there is when we go into the investigations. I would still start with her partner and then move on to her.
Okay.
Yes.
Okay. All right. I'm looking for other SMSs that, you know, would be conducive for this particular interview, seeing as we're talking about conception and pregnancy. Quite a number of people have, you know, different questions altogether. But let's move on, and then we've discussed about the miscarriage, and then now I want to, you know, talk about the stillbirth scenario that happens. And there's even a report in the newspaper where the First Lady has spoken and said, as much as we have taken care of maternal health, we're still seeing quite a number of people who are experiencing stillbirths. So maybe you can explain to us what exactly a stillbirth is and what causes it, and how to avoid, if we can avoid it.
Okay. So as I said, in Kenya, I would say a stillbirth would be any pregnancy that's beyond 28 weeks and the baby unfortunately dies. A stillbirth would be the baby dies in the mother's womb. Okay. Now, reasons are several. Okay, and we'd start with something like, again, the congenital malformations. Okay. Then we have things like, has the mother bled? We can have, like, the mother could have like an abruptio. An abruptio is when the placenta shears off, and sometimes we don't see the evidence outside. It's concealed. So if that happens, definitely the baby cannot live without supply of nutrients and oxygen from the placental bed. Cord accidents, again, very common. So cord accidents could be baby is very active, and usually because you find earlier in the mid trimester, the amount of water vis-a-vis the size of the baby is really a lot. So they have lots of room to jump about and play about, and we've had unfortunate incidences, and so you find it loops around, it goes around the leg, body, neck, and what have you, and you just get an unfortunate cord accident. Things like diabetes, things like any other endocrinological problem. We have infections. There's so many. Basically, what would cause again early miscarriages would again be linked to
later. Okay. Now, also uterine abnormalities with the fetus. I mean, with the, what do you call it, the uterus. So you find if somebody has congenital malformations, but then again, I wouldn't want to mix stillbirths, because we also have preterm deliveries, whereby again mother delivers before time, and because the baby is just too immature, baby won't survive. Okay, we're coming to the end, but there's a final question. Fact or myth that doctors, gynecologists, Dr. Owiti, can help me get twins, triplets? Is that true, or is it a false story altogether? But there's a rumor that, you know, you can come and see Dr. Owiti and she'll be able to work the calendar out, and then she'll be able to give you twins or triplets, and if you want 2 boys, 1 girl, 3 boys.
Okay, if you want a natural conception, yes, I'd just like to say, very unfortunately, that would be a myth. That would be a myth. Yes. But definitely, again, you must look at, there's the ethical side of our medical profession. You find that, for example, people with, for example, the husband has, say, the obstructive azoospermia, and they have to undergo an IVF cycle. Those couples are more likely to have multiple gestations. Okay. Reason being, if you return more fetuses, you have a higher chance of conception. But again, we have to do it within reason. We wouldn't put too many, because again, this area, the issue of trying to do what we call an embryo reduction is not really taken very well. Okay. So you really have to balance between the number of embryos you want to return into the mother's womb, and because she'd have to carry those. So if she had triplets, she'd have to carry the triplets. There's really nobody I'm aware of who's doing embryo reduction in this part. Okay. The final one, because there's someone who's screaming in my ear. Ask the doctor, can the doctor help me, you know, get a girl or get a boy? You know, there are those people who just want girls. Again, as I've said, in natural conception, how many sperm are released? There are millions. Yes. How do I decide of these 40 million sperm, it's the one with a girl that's going to come through? So I'll just tell them, what we do know is that the male gametes travel much faster. So there's some thingy of you have to have sex at time of ovulation. Yes. Who exactly knows what time they're ovulating? So really, I wouldn't bet my money on it. I'm sure there's some other people who'd say I have a different view, but for me, scientifically, not really. That one goes out to our director. He was asking, you know, I think he wants a girl. So he's just wondering, when exactly can I get a girl? All right, Dr. Owiti, thank you very much for coming. Quite a number of things have come up, quite a number of questions, and we've just talked about, you know, conceiving and the pregnancy. There's post, you know, pregnancy. There are also conditions within the pregnancy that we'll need to discuss. So we'll plan and we'll have you back here so that we can have those discussions. But thank you very much for making time for us and for educating us this morning. Really appreciate it. We're coming to the end of the Power Breakfast show. We're hoping that you've been informed, you've been educated, you've been entertained. And on behalf of my team, I want to say thank you for joining us. To have yourself a fantastic Tuesday. We'll see you tomorrow, same time, same place. Don't forget to be kind to one another. Don't forget to smile. For now, it's Simply Thomas who's going to take us to the top of the hour. Good morning.